and I will be asking you a few questions. But this is an interactive session, so you guys have already been taking lectures and all of that. Today I will be asking you more than actually talking. So you can either talk to me, and you can open your mic and talk, or you can write to me in the chat, and inshallah I will see, and we will have fun. Okay.
Doctor, sorry to interrupt. Can you please record the session?
Sure.
I'm recording it, خلاص.
طيب تمام. Thank you. Just before I start, disclaimer. I am a teaching assistant, so I don't put questions. The questions will be put by the faculty, either the ones who taught you in lab or Dr. Akif himself, who's giving you the lecture. So in case you find anything that's contradicting, in case you find anything that's confusing, I hope you don't, you always follow whatever the faculty says, okay? Okay, so to start, let's first of all know the source of blood supply to the brain. So what are the two sets of branches from the dorsal aorta that supply the brain? The two main sources for blood supply to the brain, the things that make the anterior and the posterior circulation. Do you know the names of the arteries?
Internal carotid.
Okay, internal carotid for the anterior circulation. What makes up the posterior?
Vertebral artery.
The vertebral artery, excellent. So the internal circulation is from the internal carotid. The posterior circulation is from the vertebral arteries. Now, just for a quick orientation, we know that the common carotid artery arises from the aorta. I don't want to go further below the common carotid. This common carotid comes from the aorta, and then it divides, it bifurcates at the level of C4 into internal and external carotid artery. External carotid supplies usually the face and the scalp and the meninges, whereas the internal carotid artery supplies, it goes without giving any branches until it reaches the brain, and then it gives off the major branches to supply the brain itself. Now, the course of the internal carotid artery is that it runs along the carotid sheath inside the in the cervical part, and then it runs in the carotid canal, and then it exits in the foramen. Here, you can see it. It exits in the foramen here, and then it will again, and then it will divide. Okay. Whereas the posterior circulation, it's the vertebral artery, so it will be running along the vertebra. You have two vertebral arteries that will unite to form one basilar artery, and then that basilar artery will give you terminal branches to supply the posterior part of the brain. So this is the oblique line that separates the anterior circulation from the posterior circulation, okay? And this is just a more detailed image. Now, what are the branches of the anterior carotid artery? Let's focus on anterior circulation now. What comes off from the internal carotid?
Middle cerebral.
The middle cerebral. Okay, what else?
Posterior communicating.
Posterior communicating, صح. What else?
Anterior cerebral.
Anterior cerebral, excellent. So these are the three main branches. Hypophyseal, someone said, correct. What else?
Choroidal.
Anterior choroidal. There's one more left.
Ophthalmic.
Ophthalmic, excellent. Now, let me give you a scenario. So, you have a patient. Basically, he was brought to you. You are an ER physician. He was brought to you in the ER after a motor vehicle accident, okay? And he has a face injury. Now, when you examine the patient, you notice that he has profuse bleeding from the area surrounding his eye and upper face. And you notice that he has proptosis of the right eye, same area where the bleeding is. Can you explain to me why this bleeding is so profuse? Can you tell me the source of bleeding?
Facial artery, where it anastomosis with the ophthalmic artery.
Excellent. So in particular, the angular division of the facial artery. So this is where you see here, this is the angular division of the facial artery, that comes from the external carotid artery. And this is where the ophthalmic artery is, which comes from the internal carotid artery. So this is an area of anastomosis of two huge arteries. And that's why this area here, when it's injured, it puts a risk for very, very heavy bleeding in the patient. Okay. So this is our first scenario. You guys, I'm making it a quick session. I know you have midterm on Sunday. You have a lot to study. But at any point, if there's anything you want me to repeat, or if you have any questions, please stop me or write to me in the chat, and I will respond to you, inshallah. Now, for the second scenario for today is anterior choroidal archy. You have another patient. Again, you are an ER doctor. Your patient is an elderly. He has a bleeding disorder. He has a risk for increased thrombosis. And he was brought to the ER with reduced consciousness and neurological abnormalities. You, as an ER physician, you did an angiogram, and it showed that he had an anterior choroidal artery occlusion. Okay. What neurological abnormalities do you expect this patient to have? First of all, what does the anterior choroidal artery supply?
The ventricular system.
Ventricular system, excellent. What else? Internal capsule, thank you. طيب, the internal capsule is what?
It's where the tracts converge.
Okay, so it's where the tracts pass. It's basically an area of white matter that is separating, that is existing between the gray matter nuclei in, like, basically inside the brain. And this is where a lot of tracts are passing. And since the anterior choroidal artery supplies the internal capsule, so what do you think the patient will present with? One of your friends is saying emotional and behavioral abnormalities. It could be, but what else that is more significant?
Also some weakness since corticospinal tract is passing there also.
Excellent, excellent.
Contralateral hemiplegia, maybe?
Excellent, excellent.
Yeah.
So we have hemiplegia. So first of all, we
paralysis.
Paralysis of?
Because of the posterior limb of the internal capsule.
Excellent. Okay. So we agree that there is a motor deficit, and we agree that it's contralateral because the motor fibers still did not cross in the medulla. We are still up. So everything will be contralateral. So is there anything else?
Loss of sensation.
Loss of sensation, excellent.
Ipsilateral loss of sensation from the body.
Excellent. Okay. So these are the neurological abnormalities that we expect in anterior choroidal artery occlusion. And basically here what's it called? The important part to know here is that even a small artery like the anterior choroidal can give you very big manifestation only because of the internal capsule. Now, this is just to tell you what the internal capsule is. These are the basal ganglia. So this is the thalamus. This is the caudate and putamen, and you have a lot of the basal ganglia in general. And then you have the white matter here, and this is the internal capsule. It has the center, the genu of the internal capsule. It has the anterior limb, and it has the posterior limb. We will talk more about it in detail when we speak of we will speak of its blood supply when we cover the cerebral arteries. Okay, but you already have an idea of what passes as in the tracts. Okay. Now the hypophyseal archy is basically just makes up the circulation for what organ?
Doctor, I have a question if you don't mind about the previous one.
Sure.
Why is it ipsilateral loss of sensation?
لا, it's contralateral for both.
Okay.
Not ipsilateral. Okay. What was I saying? Yeah. So the hypophyseal archy supplies what exactly?
The pituitary gland.
The pituitary gland. Excellent. So it supplies not exactly part of it, the pituitary, and it supplies the infundibulum. The infundibulum is the connection between the hypothalamus and the pituitary gland. So basically the hormones that are made in the hypothalamus, the way for them to enter the pituitary gland is the infundibulum. And the hypophyseal artery makes up the blood supply of that system. So basically, if there was any hypophyseal artery occlusion, hemorrhage in that area, anything, the entire pituitary system will be shut down, and there will be no more pituitary hormones. Okay. Now these are the three. I don't want to say small, but these are the three side arteries that are coming from the internal carotid. Now let's talk about the big guys. The first one is the middle cerebral artery. The first thing you want to know about the middle cerebral artery is that it is a continuation of the internal carotid artery. What does that mean? It means the internal carotid artery is giving off branches along its way. But when it reaches, let's say here, yeah. So the internal carotid artery is giving branches along its way, and then it gives off the anterior carotid artery, and then it continues as the middle cerebral artery. So this makes it significant because any embolus or any problem in the internal carotid, the easiest way for it to transmit into the brain is the middle cerebral artery, okay? That's why the middle cerebral artery is usually the most likely involved in any cerebrovascular accidents, okay? Any embolism, any infarct, the most common area to be infarcted is usually the middle cerebral artery territory because it is a continuation of the internal carotid artery. Now, what happens basically is that it courses along the lateral surface of the brain. You see here, this area is color-coded. So the red area is the area where the MCA is. It courses along the lateral surface of the brain. So you see that it covers part of the frontal lobe. It covers the superior part of the temporal lobe, and it covers the medial part of the parietal lobe, okay? Now to look at it in more detail, we know that as we agreed, it covers the bulk of the lateral surface of the hemispheres. It covers the frontal lobe. What is there in the frontal lobe? Let's put it this way. The frontal lobe is mainly responsible for
Broca's area.
For
okay.
motor.
For motor.
Motor.
Excellent. Okay, so part of it is motor, as in movement, or part of it is, when it comes to speech, it's Broca's area. So basically language expression. يعني حتى this has to do with motor movement, صح? لأنه you're expressing, you're articulating, you're talking. So Broca's area and the motor division for movement. The inferior division of the MCA supplies the temporal lobe, and the temporal lobe has another area for language, which is
Wernicke's area.
Wernicke's area, which is important for us to understand what people say. So it's important for language comprehension. Now, it has also deep branches that go and supply inside the brain. So I think there was a picture here. Yeah. So it has deep branches that go inside and perforate and supply inside of the brain, which is the basal ganglia system here. Okay, we will notice by the end of the lecture that, or by the discussion, that all cerebral arteries will contribute to the basal ganglia, but in different ways. But the lenticulostriate artery, so basically the artery that gives off the most supply to the inside of the brain is the MCA through the lenticulostriate arteries, which are these arteries, okay? They are small perforators that go in and they perforate, they supply the basal ganglia. Tamam. Now, the brain as a whole has, it has a motor area in the frontal lobe, it has a sensory area in the parietal lobe. But it's different when we have an MCA infarct from an ACA infarct in the location of involvement in the body. The way to know that is, as you see here, the motor homunculus, or the sensory homunculus. If I have an MCA infarct, and we said that we are mainly concerned about the lateral aspect of the brain here. The MCA supplies the lateral aspect of the brain. So which area of the body do you expect to be injured?
Face and hands.
The face and hands, excellent. So the person will have weakness in the upper part of the body and in the face, okay? And because the person will have طبعاً both motor and sensory, but upper part will be affected. And because we have the language area affected, so what will he have as well? What is the term
Aphasia.
for aphasia? Excellent. So this is a term for inability to talk. So these people will be silent. They cannot comprehend what you tell them, and they cannot reply to whatever you say, okay? Because of Broca's and Wernicke's areas. And anytime we have the basal ganglia involved, we will have problems in, you guys took the basal ganglia or not yet?
No.
No, not yet.
No.
So the basal ganglia, but in general, it's important for coordination of movement. Yani patients who usually have basal ganglia problems, they will have more rigidity. They will have, even if they can move, their movement will not be normal because basically supervisor of movement is the basal ganglia, okay? It's enough to know for now, and it has a lot of more functions, but it's complicated. But know that it's higher mental function and coordination of movement, okay? And as you can see here, the internal capsule that's supplied by the MCA is the genu and the posterior limb, okay? Which is, I think some of you mentioned it already. And the genu and the posterior limb contain that, as this slide says here, it contains the genu contains the corticobulbar, and the posterior limb contains the corticospinal. So corticobulbar is for the face, corticospinal is for the body. Okay, and that's why that increases the risk for patients having upper body involvement. Tamam. And we spoke about the lenticulostriate. Now, when we say middle cerebral artery occlusion, can you summarize to me what are the findings that we will see? We discussed some already.
Contralateral hemiplegia.
Contralateral hemiplegia. Your friend said apraxia. Okay, what else?
Aphasia, motor and
Aphasia.
sensory.
Excellent.
Yes. If Wernicke's area is of dominant hemisphere, then you have Crestline syndrome.
Excellent.
If on the non-dominant area, then hemi-neglect syndrome.
Excellent, excellent. And we have your friend is typing homonymous hemianopia. Because of the visual pathway,
Yes.
it will be affected. And we have the final thing is sensory loss. So we will have contralateral hemianesthesia. Okay?
Hemianesthesia.
Tamam. Now, you mentioned already, there will be a difference between if the MCA was in the dominant or the non-dominant part. The dominant is usually will affect the language areas. However, the non-dominant part will affect your the way you comprehend life. So you will be seeing things, but you will not be able to recognize them the same way. This is expressed by hemi-neglect syndrome. So patients will be neglecting the contralateral side of their body. Okay, so they will be taking care of only half of their body, and the other body they're not even aware of its presence. Okay. Homonymous hemianopia, what does it mean? You have any idea?
Doctor?
Afwan?
What do you mean by dominant and non-dominant?
Okay, so you know that some of us are right-handed and some of us are left-handed. Why is this? Because one side of the brain is dominant over the other side. Okay, and because one side is dominant, so a language, a function as important as language is present on that side, the dominant side. For example, I am right-handed. My dominant brain is the left lobe. My dominant hemisphere, I have a left dominance. Okay, معناها أنا the language areas that are acting, that are working in me are the left side. So if I get an MCA infarct on the left side, I will have aphasia. But if I get an MCA infarct on the right side, which is the non-dominant side, I will have hemi-neglect syndrome. Okay, you flip this when patients are left-handed. طبعا هي handedness is one way of knowing which side is dominant, but it's not always very accurate. But it's the most commonly used way. If some person is left-handed, معناها بالعكس, so the person will have right-sided dominance, and the right hemisphere will be dominant over the left. So right language area infarct will have aphasia. Left infarct will give you hemi-neglect syndrome. Okay, this is what we mean by dominance.
Okay, thank you.
Okay, I was asking, do you know what is homonymous hemianopia?
I think, for example, if the left cortex is affected, so the right visual fields of both eyes wouldn't be there, I think.
Okay, so did you study the visual pathways ولا لا؟ لأنه if you did, then I can explain. But if you didn't, no need.
Yes, we did take it already.
Okay, so homonymous hemianopia, let's say I draw two circles. Let's say this is a circle or this is a circle. Homonymous hemianopia is when I lose the outer part of both, for example. Okay. That's homonymous hemianopia, and I don't have a picture for this. I'm sorry, but I think you got it. You can if you can refer back to the visual pathway, and I didn't prepare it. I thought it's not part of this. I think you might be taking it more in the brainstem. You guys have taken any brainstem review or not yet?
No, but Doctor, how is that different to bitemporal hemianopsia?
Oh, yeah. This is what I meant, but and I didn't. The circle is not drawing. Wait, let me check if I can. هو basically what your friend said is correct. It's basically missing the same what's it called? It's basically missing the same visual field in both eyes. Okay. Let me check 1 second. So you guys are recording the session, but I doubt you will have time to go back and listen to it. بس يعني I hope it's helpful.
It'll be useful for the final.
Okay, I'm just trying to get you a picture to see the types. All right. Okay. So you see this new slide. So homonymous hemianopia is this. So the same visual field on both sides is gone. This is left homonymous hemianopia due to a lesion on the right optic tract. You know, the optic tract passes through the temporal lobes in order to get through the parietal and the temporal to get to the occipital, صح? So because the MCA supplies the lateral part of the parietal and the temporal, so there will be a disruption in the optic tract, and that's why the person will have left homonymous hemianopia. When you study this in more detail, you will know, it depends whether it's in the parietal, whether it's in the temporal, you will get different either quadrantopia or complete hemianopia, okay? I don't want to go in details in this, but if you guys are interested, I can prepare a different talk on it and we can explain it more, okay? طيب, now going back. Okay, going back, we said basal ganglia will be involved because of motor control. So there will be problems in motor learning and in motor control. The internal capsule, again, the same motor and sensory manifestation will be again there because of the internal capsule. Apraxia because of the supplementary motor area. You know what that is?
I think it receives the input from different parts of the body and feeds it to the primary motor area.
Yes, correct. And it's there in the frontal lobe. And then you have executive functions, yes, and behaviors and emotions will be affected because of the respective areas in the frontal lobe. Okay?
Yes.
Now we finished the middle cerebral artery. Do you have any questions? Okay. Now for the anterior cerebral artery, it's the opposite. So the anterior cerebral artery courses on the medial side of the cerebral hemispheres. It covers both the frontal and the parietal and the temporal lobes, but from inside, as you see here. Okay. Now the anterior cerebral artery, it supplies as the anterior four-fifths of the corpus callosum. It supplies the lateral surfaces of the frontal and the parietal lobe, and it supplies the anterior portion of the basal ganglia and the internal capsule. The unique part to remember here is the olfactory bulb and the tract. Okay, so this is unique. So anything related to olfaction, anything related to the sense of smell is covered by an anterior cerebral artery. So anterior cerebral artery infarct will give you any idea?
Anosmia.
Anosmia, excellent. So inability to smell. Okay. Okay. And as we agreed, all arteries will eventually contribute to the basal ganglia, and this one is contributing through anterior portion of the basal ganglia and the internal capsule. So so we said the posterior limb of the internal capsule is by the middle cerebral artery. The anterior limb of the internal capsule is by the anterior cerebral artery. Okay, and the anterior portion of the basal ganglia. Now, anterior cerebral artery syndrome, what do you expect there will be? What do you expect the patient to present with?
Also hemiplegia contralaterally.
Okay, but here, which
And
side of the body?
hemianesthesia.
Which part of the body will be affected here?
Oh, lower body.
Lower body, excellent.
Lower part of the body.
Okay, what else?
Anosmia.
Anosmia. What else? Apraxia. Again.
Apraxia.
Okay, thank you. What else?
Aphasia. Or no.
Okay.
No.
Yeah, aphasia is only in
Yeah.
MCA.
Yeah, yes. So
Okay.
that's that one.
Thank you. So your friend said urinary incontinence because we agreed that it covers the lower side of the body. So there will be pelvic floor weakness and there will be urinary incontinence, not because of autonomic problem, but because of higher cortical function that is lost. Okay. Again, we have sensory deficits, command contralateral and in the lower body involving the perineum. And the rest you already mentioned. Here, best we need to know the medial lenticulostriate vessels come from the recurrent artery of Hubner. And this is important to add to the perforators. So we agreed in the lenticulostriate arteries, they mainly come from the middle cerebral artery. The perforator of the anterior that comes from the anterior cerebral artery is the medial lenticulostriate artery, which comes from the recurrent artery of Hubner. Okay. Now we finished the anterior circulation. Any questions? We finished the anterior, let's say 2/3 of the brain. Now, when we come to the posterior circulation is made up by 2 vertebral arteries that will eventually make the basilar artery that will give you the branches that will supply the posterior part of the brain. However, before the vertebral arteries unite, first of all, they will give you posterior spinal arteries, the ones you see here. So these are 2 posterior spinal arteries. And both of them will contribute to the formation of a single anterior spinal artery. Okay, so we have 2 posterior spinal and 1 anterior spinal to supply the spinal cord along its length, so all the way down. It will also give you the posterior inferior cerebellar artery, which is pica. And then it will make the basilar artery. Now, the basilar artery, before it gives you the posterior cerebral, what it will give you first of all, the ICA, which is the anterior inferior cerebellar. And it will give you pontine branches, and it will give you the superior cerebellar artery. So now we covered the blood supply of the cerebellum. So blood supply of the cerebellum is basically by a posterior inferior cerebellar artery that comes from the vertebral arteries, and then anterior inferior cerebellar artery and superior cerebellar artery that come from the basilar artery. Okay. The pons are also supplied by the basilar artery through the pontine branches, the small ones that you see here. Then when the basilar artery is done, it gives you as a final division the posterior cerebral artery, okay, which is the artery that will supply the posterior part of the brain and the final part. Now, again, to talk about the basilar artery, we said it arises from the union of the 2 vertebral arteries. It's superior and anterior over the pons. It has multiple perforating branches, and the final branches we spoke about earlier. The same, just another picture. Now, the posterior cerebral artery, by the way, there are like brainstem problems that will happen when you have injury to the basilar artery and to the vertebral artery. However, I didn't go in details in them because you guys still haven't taken the review session for the brainstem. So I think you need to know that first, so that you know why is something contralateral and why is the other ipsilateral. Otherwise, it will be confusing to you. So I think you need to cover brainstem in more detail. And then after that, if you would like at any time to email me to talk about the blood circulation in that area specifically, then I will be happy to prepare something special for the brainstem. Okay. Now for the posterior cerebral artery, that one is very easy because it only supplies the posterior part of the brain, which is mainly the occipital region. Okay. So this region here, the one in blue. And the inferior part of the temporal lobe, so the part that is left from the MCA and ACA is supplied by the posterior cerebral artery, but the main supply is the occipital lobe. The posterior cerebral artery is this artery over here. And as you see, it courses around the midbrain. So بطريقه, it gives off midbrain branches as well. Again, it supplies the posterior lobe. Now, the posterior artery contributes to the basal ganglia by the thalamostriate branches. Okay, so we have the medial lenticulostriate branches from the ACA, the lenticulostriate, the arteries from the MCA, and we have the thalamostriate branches from the ACA. Okay, I have a different slide for them. Now, when we have posterior cerebral artery occlusion, what do you expect to see in the patient?
I think inability to recognize objects,
Agnosia.
Agnosia, excellent. Homonymous hemianopia with macular sparing, excellent. What else? Okay, so we will have contralateral homonymous hemianopia with macular sparing. You will have, what's it called? Cortical blindness, so the person cannot see because of cortical problem, but the eye itself is normal. Visual agnosia is that you cannot know anything that you see, you cannot recognize anything. Prosopagnosia is what exactly?
You cannot recognize the faces.
Okay, including the person's own face, and this is because of the temporal lobe. In particular, the fusiform gyrus. You will have alexia and agraphia. What are alexia and agraphia?
Agraphia maybe cannot write.
Okay, so agraphia cannot write, alexia cannot read. Thank you for those who answered on the chat. And you will have a memory defect because of temporal lobe involvement, the inferomedial part of the temporal lobe. And you will have signs of injury to the thalamus. I will not go in details. They will most likely be sensory deficits, but I will not go in detail because this will be part of the basal ganglia that you will cover after your midterm. So don't worry about it for now. But no, there are perforating branches that reach the thalamus. And so if there is a posterior cerebral artery problem, you will have a thalamus problem. Okay, so basically the most important thing to know, let's say now, let's summarize. So we have the middle cerebral artery. It will give you contralateral motor and sensory deficit, but involving the upper body. Important things to keep in mind are the homonymous hemianopia and the, what's it called? The inability to speak if it was in the aphasia, if it was in the dominant hemisphere, and the hemineglect syndrome, contralateral hemineglect syndrome, if it was in the non-dominant hemisphere. So this is very important for MCA. If you see any of these, it's a straightforward MCA question. ACA, what is unique about it is motor and sensory deficit in the lower part, including urinary incontinence, and anosmia because of the olfactory bulb. PCA, what is important about it is the macular sparing. So anytime you see any visual defect with central sparing, macular sparing is what is sparing of the center. When you see someone who has macular sparing, you know that there is a lesion in the occipital lobe immediately. So the lesion that you have here is a posterior artery occlusion, for example. Okay, so this is important, and prosopagnosia and agnosia. So any agnosia is posterior cerebral artery, including alexia and agraphia. Okay. This is, as we said, and we will, as I told you, and I will summarize the perforators at the end. So these are the perforators: the MCA, lenticulostriate, which will cover the basal ganglia, the internal capsule, and the corona radiata. You will know these in more detail when you study basal ganglia. And for now, don't freak out. Just know the names, but they will be easier to you later on. The anterior cerebral artery will give you the lenticulostriate, which cover the optic chiasm, the hypothalamus, and the anterior limb of the internal capsule. The PCA give you the thalamoperforators, okay, which cover the thalamus in particular. Now, we have different arteries. Now, these arteries are connected to each other through the circle of Willis, okay? So the circle of Willis is basically a system which is important to maintain circulation in the brain, even if one of these arteries is occluded. So we need to have anastomosis so that other arteries can cover up for the occluded artery. So what you see here, so for example, this is the internal carotid artery. It gives you the anterior cerebral artery and the middle cerebral artery. This is the, what's it called? This is the posterior communicating artery, and this is the posterior cerebral artery that is branching as a terminal branch of the basilar artery. Now, we have anterior communicating artery and posterior communicating artery. These are the ones that close off the circle. So here, if you notice, you will have a full circle. This circle is known as the circle of Willis. And basically, the importance of this circle is that it maintains blood flow to the brain, even if there was a blockage on one of the arteries. So one of the anterior cerebral arteries here is blocked, for example. The anterior communicating will provide some blood supply to the blocked side of the brain, okay? However, these arteries are small, so not always the compensation will be enough. So you will have deficits at the end of the day, but they will be much less, okay? Now, the anterior communicating artery, what's important about it is that aneurysms of the artery, of this artery, are the most common among the other arteries in the circle of Willis. And because, if you notice, this is the optic chiasm. So because this is a very close in relation to the optic chiasm, so any aneurysm in this area will compress the optic chiasm, and that's why the person will have bitemporal hemianopia. So now we covered 3 types of hemianopia. We have the homonymous hemianopia from the MCA. We have the contralateral homonymous hemianopia with macular sparing with the PCA. And now we have bitemporal hemianopia because of anterior communicating artery pathology, most commonly an aneurysm. Okay. I have a few questions at the end, but I wanted to review first. Posterior communicating artery has other pathologies, to be honest. It has dissection, it has an aneurysm. However, I think Dr. Akif, I didn't find them in his slides, so I didn't want to include them to you. I think you are not required to know them. So just know, this is the posterior communicating artery. It's the last branch of the, down from the internal carotid artery. Okay, that is connecting the anterior circulation to the posterior circulation. Now we come to the questions, but before that, do you have any questions for me? Okay. Okay. Right. So for the questions, yellow. Which of the following is the most commonly occluded artery?
C.
C is anterior communicating?
No, MCA.
MCA. Okay. Anyone would like to volunteer to read the scenario? Or shall I read it for you? Okay, I will go on. So a 70-year-old right-handed woman comes to the emergency department with left-sided visual loss that she noticed on awakening in the morning. She has no headache, slurred speech, difficulty swallowing, weakness, or difficulty walking. Her other medical problems include hypertension, atrial fibrillation, and hyperlipidemia. Blood pressure is 170 over 102 millimeter mercury, and the pulse is 90 minutes and regular. 90 per minute and regular. On neurologic examination, she is alert and oriented to person, place, and time. Her speech is fluent, and she follows complex demands. So, so far she is okay, except for the left-sided visual loss. Examination of her visual field shows left homonymous hemianopia with macular sparing. There is decreased sensation over the left side of her body. The remainder of the neurological examination is within normal limits. Non-contrast head CT demonstrates an area of focal parenchymal hypoattenuation as shown in the image. So which of the following arteries is the most likely affected? A, PCA. So to analyze the scenario, basically she is someone who has a lot of risk factors for atherosclerosis and blood disorder, vessel disorders in general. Her only complaint is left-sided visual loss, and she has decreased sensation on the left side of the body. And she has an area that is affected. So this is the occipital lobe that is affected on the CT, the non-contrast CT. And that's why it is a posterior cerebral artery affected. Now, remember when I told you there will be a thalamic problem, the thalamus manifests usually as sensory loss. That's why she has sensory loss, because of the thalamic lesions that are given off from the PCA. Okay. Now, the second scenario, a 68-year-old man is evaluated for visual loss in the left eye. That resolves spontaneously within several hours. The patient has a history of hypertension, type 2 diabetes, coronary artery disease, and ischemic cardiomyopathy. He has smoked a pack of cigarettes daily for the past 40 years. Physical examination reveals a left carotid bruit, but no neurological deficits. A carotid duplex ultrasound shows 85% stenosis of the left internal carotid artery. The carotid angiography and carotid angiography with stenting is performed. During the procedure, atherosclerotic debris embolized to the artery shown in the red arrow on the cerebral magnetic resonance angiograph below. Which of the following will be most likely impaired in this patient? Right. So first of all, in order to know what of these functions will be lost, we need to know what artery is pointed at by the red arrow. What is the artery that's tell me what's the artery that's the red arrow? Don't answer. ACA. Okay, so ACA is the anterior cerebral artery. Which of these functions is a function of the anterior cerebral artery? Think in relation to the homunculus. Remember the motor homunculus we spoke of?
Is what?
Okay, someone said A, climbing stairs. Thank you. Yes, excellent. So it will be a lower limb deficit that will lead to problem in climbing stairs. If I had in the choices instead of climbing stairs, for example, urination or control of bladder, then that would be the answer as well, صح? Because the lower body is affected, the person will have urinary incontinence at the end of the day. Okay, so is it clear? The scenario might be long and confusing, but look at the end, look at what they want. So they want you to know what is the red arrow pointing at, and they want you to know the function of that artery. Okay, even though the scenario is long, but it's very easy. Okay, now the last scenario. A 65-year-old man is brought to the emergency department due to acute onset, right-sided weakness, and slurred speech. He also has a severe headache and nausea. Medical history is significant for poorly controlled hypertension and chronic tobacco use. Blood pressure is 240 over 120 millimeter mercury, and pulse is 104 per minute. On physical examination, the patient is lethargic with right hemiparesis, lower facial weakness, right hemisensory loss, and dysarthria. Non-contrast CT scan of the head is shown in the image below, and this is what you see. Which of the following arteries is most likely affected in this patient? Lenticulostriate artery. Yes, that's one answer. Yeah. Do we agree?
Yes.
Okay, thank you. So the dysarthria here is, okay, someone said B. So B is correct because it's the source. The middle cerebral artery gives you the lenticulostriate arteries. However, the middle cerebral artery is very, very big. And the area that we see here is not frontal, not parietal, not temporal. It's specifically basal ganglia. That's why we want you to know it's lenticulostriate, not middle cerebral in general. Okay. This question might be a tiny bit confusing. By the way, these questions are questions that I got from a question bank. They are not from the university. If they were difficult for you, then don't worry about it. But I just wanted you to know, the middle cerebral artery is very big. So depending on the section that's involved, you need to name that part that's involved, not the middle cerebral artery in general. Okay, because this is the area that's involved particularly. Okay, and this is just an image, diagnosis. So this is what I have for you. I believe blood supply is a very straightforward topic. I already spoke to the people who are teaching you, and they told me, it's a straightforward topic and you shouldn't worry about it. But in case you have any questions, or you have anything, please let me know. I will be happy to help you either by email or the way you would like. And I hope this was helpful for you.